Good morning, everyone. Welcome to Journal Club. We have two very important articles being presented this morning, and the first up is Mauli Mehta with the short presentation on the STRIDE trial. Go ahead, Mauli.
Thank you. My name is Mauli. I'll be presenting on the effect of depth of sedation in older patients undergoing hip fracture repair on postoperative delirium, the STRIDE randomized clinical trial. I have no conflicts of interest. So we know that the risk of delirium in older adults after major elective surgery is between 10 to 25% and even higher for non-elective hip fracture repairs. Sedative drugs are administered in addition to anesthesia intraoperatively, typically propofol, and that helps relieve anxiety, discomfort, pain, and diminish memory of the event. Delirium management usually involves prevention by control and elimination of modifiable risk factors, and so one risk factor may be the sedative medications. So this trial was published in 2010, the sedation depth during spinal anesthesia in elderly patients, looking at post-op delirium in hip fracture repair. And it was a double-blind randomized control trial at Johns Hopkins Bayview Medical Center. They included patients over the age of 65 undergoing hip fracture repair with spinal anesthesia, and their choice of sedation was propofol. They excluded patients that had contraindications to spinal anesthesia, a prior hip surgery, language barriers, severe congestive heart failure, and pulmonary disease. They used a bispectral index, which is the use of EEGs to try to target the sedation level. It ranges from 0 to 100, with 100 being alert patient and 0 being comatose. And they defined a deep sedation group as about 50 and the light sedation group as 80 plus. And they found that there was a significant difference in postoperative delirium in light sedation versus deep sedation. And so they concluded that the prevalence of delirium can be decreased by 50% with the light sedation group compared to the deep. But because they used bispectral index, it was criticized that it's not routinely used for managing sedation. And there is some data showing poor correlation, particularly in ICU patients. And they also had multiple sedative agents used intraoperatively, and so propofol-specific effects were difficult to conclude. And so this study, which is going to be published soon in JAMA Surgery, it's currently available as an e-publication, the STRIDE randomized clinical trial was conducted. And their study objective was to see whether limiting sedation levels during non-elective hip fracture repair under spinal anesthesia reduces postoperative delirium. This was a randomized two-group parallel superiority trial, again at Johns Hopkins Bayview Medical Center, and included patients over the age of 65. This was conducted between November of 2011 and May of 2016. They randomized patients one-to-one to receive heavier sedation versus lighter. And in this case, they used the Modified Observer's Assessment of Alertness Sedation Score, OAAS score. And they defined heavier sedation as 0 to 2 and lighter as 3 to 5. Their choice of sedative here was propofol as well. And their primary objective was to assess delirium post-op day 1 to day 5, or discharge, whichever came first. And secondary objective was to assess the interaction between baseline comorbidity and propofol sedation levels in determining delirium incidence. They included patients that were admitted to Johns Hopkins Bayview Medical Center for surgical repair of acute primary traumatic hip fracture, age over 65. Patients had to have an MMSE done, and the preoperative MMSE score was 15 or higher. And they had to receive spinal anesthesia, which they defined as 15 milligrams of bupivacaine and 25 micrograms of fentanyl. They excluded patients that were receiving general anesthesia and couldn't speak or understand English, severe COPD and CHF, those that refused informed consent, of course, non-participating attending surgeon, if they had a hip fracture in both hips at the same time, or you were repairing another fracture concurrently. If there was a prior hip surgery on the same hip, they excluded the patients, and if there was preoperative delirium or severe dementia. Their primary outcome was incidence of delirium from post-op day 1 to day 5, or hospital discharge, whichever came first. And for their secondary outcomes, they looked at MMSE scores and the delirium rating scale revised 98, the DRS, severity and total scores during the first 5 post-op days or until hospital discharge. And delirium diagnosis was made by a multidisciplinary consensus panel, which was based on that included data from CAM, DRS, digit span, a review of medical records, family and nursing staff interviews. So it might be difficult to see this, but this just shows that they had about 200 patients that were randomized, 100 to each the light sedation and the heavier sedation group, and they pretty much followed up on most of them. 4 people were lost in follow-up in the lighter sedation and 3 in the heavier sedation group. The table 1 shows baseline characteristics, and they were similar for age, gender, education level, residence, employment, and this is again the baseline characteristics continued. So the groups were similar with respect to physical self-maintenance scale items and instrumental activities of daily living items. They also looked at the CAGE score, and there was a 7% in the lighter sedation as opposed to 20% in the heavier. The MMSE score, the mean MMSE score was about 24, and the GDS about 3.8 in both groups. The type of fracture and surgical procedure did not differ. This shows the intraoperative and postoperative data. So the separation between groups, they said, was good. The OOAS criteria in the heavier was 0 and 4, which 0 basically indicates that the patient does not respond to nauseous stimuli, and 4 is the lethargic response in calling name and tone. The total propofol dose was, of course, higher in the heavier sedation group. And as a result, the time to end of surgery was longer, getting out of anesthesia. And intraoperatively, they only used propofol. Postoperative morphine doses were equivalent. So without adjusting for comorbidities, the incidence of delirium in the heavier sedation group was 39%, and in the lighter sedation group, 34%. And this was not statistically significant. When they did Kaplan-Meier curves showing data from post-op day 1 to day 5, this cumulative incidence of delirium in the lighter sedation group was slightly lower, but not statistically significant. The secondary outcomes not shown here, but if anybody's interested, I have that. The DRS severity was higher, and the MMSE scores were lower in the heavier sedation group, post-op day 1, but again, not statistically significant. So the secondary analysis, which was looking at interaction between the Charlson Comorbidity Index score and the delirium, post-op delirium risks, showed a significant interaction in sedation level and CCI score for Charlson Comorbidity Index of 1. So here the hazard ratio for risk of delirium doubled in the heavier sedation group was about 2.3, looking at the highlighted red box there. This was lost for anything above 1. So the patients were randomized. There was concealment. The groups were similar. The study was blinded, and there was intention to treat. This was not a placebo-controlled trial, just based on the type of trial it was. Follow-up was complete. This group included primarily white females, but that's the population that's thought to have a higher risk of hip fractures. It was done at a single clinical center, and they looked at important outcomes, but I'll talk about some of the limitations, and it's unclear the benefits in here. So the strengths of the study, it was randomized. It was a 2-group parallel superiority trial. They did have a high consent rate. They did define the intraoperative differences in sedation levels, and propofol was the only sedative used. But again, the limitation is that they only use propofol, so you cannot conclude about other sedatives. It was only a single center, and they only assessed delirium testing through post-op day 5, so it cannot make any conclusions about past that day. And they only included patients with the MMSE score over 15, and their mean was actually 24. Knowing that delirium risk is increased with dementia, you're missing a good chunk of people that are high risk and may benefit from the lighter sedation. The total dose of propofol in this lighter sedation group was actually higher than the previous study I talked about. And so is there a dose that's possibly required to transition, knowing that propofol itself can increase risk of delirium? And so in this, so there was no statistically significant benefit that they found in the lighter sedation compared to heavier sedation group during hip fracture repair under spinal anesthesia. In their secondary analysis, they found that possibly the comorbidity may have some impact. So the lighter sedation levels were associated with lower postoperative delirium incidence, but the difference from the heavier sedation group was not statistically significant. Was only statistically significant for the less comorbid group. So thank you, and happy to take any questions.
Very nice, Mauli. Are there questions? I didn't just ask the first question. Is there any downside to using the lighter protocol?
In this study, they didn't find it any. But again, they didn't look at all the other. So can't say.
Okay. Any other questions here in the room?
Do you think they should redo it with CCIs of 0?
I think so, just to get a better spectrum of it, and also maybe include patients with MMSE less than 15. Their mean was 24, which if you look at the MMSE, that's half of the people are normal without diagnosis of dementia. So.
When you mentioned the DRS, are we talking about the depression rating scale?
GDS?
Oh,
DRS.
DRS.
Oh, yeah, no, the delirium rating scale,
Okay.
yeah.
Can we go over to Sinai and ask if you have any questions for Mauli?
Hi, Mauli, it's Shabir. Nice presentation. I have 2 comments. The one is that at the end of the day, I think in the overall population, a 5% absolute difference is potentially clinically important, but not statistically significant. Therefore, this study is underpowered. And I think you alluded to that, but I just want to make that clear. And I'm not sure if everyone around the room agrees, but I think going back to the first question, I think Barb asked that the downside, and I'm not an anesthetist, I think the downside of lighter sedation is relatively small. And if we could, with an NNT of 20, prevent 1 delirium, I think it would be worth a larger study to see if we could do that. My second comment is around comorbidity. And for those of you who are not so familiar with the Charlson, it's a composite of 19 different individual diagnoses that each get a point score of 1 to 6, maximum score of 37, but the vast majority of people tend to have scores of 0, 1, 2, or 3 in older populations. And the problem is that it's a relatively blunt measure. And so while it's attractive because it's a global measure of comorbidity, a lot depends on the outcomes you're interested in. And in this case, I think it fails us, and we want to stratify in future studies more precisely. So for example, if you have localized prostate cancer, you get 2 points. If you have moderate dementia, you get 2 points. They're not the same, at least in terms of delirium risk. And so we really want to be thinking about in future studies, if you want to look at this whole relationship with comorbidity, which I have a tough time believing, but if you want to stratify further and try to understand it, it would be very logical to do a study with those people who have comorbidities that increase the risk of delirium significantly, like dementia, and looking at light versus heavy sedation in that group versus those other comorbidities that aren't that important, rather than lumping everybody into a Charlson of 0, 1, 2 or higher. Those are my comments.
Thank you.
Would it make more sense to use a delirium risk tool? You know, there are different delirium risk tools for pre-op, like the Euro score in cardiovascular surgery and the Delphi in general surgery. Would it have been more sensible to look at that for the stratification instead of the Charleston?
Are you asking Mauli, or are you asking the audience, or me?
I'm asking the audience.
Yes. Can I just pick up on Shabir's point, which I completely agree with? The thing that I found interesting is they did note it was a pre-specified secondary analysis, but I don't know if they indicated what their hypothesis was for the analysis, because I don't know about anyone else. It seems to be in the opposite direction that I would anticipate. So if you have no comorbidity, if you get lighter sedation, you're less likely to get delirium, but the more comorbidities you have, the less likely is this to be impactful, which is a bit the opposite of what one might have hypothesized. I certainly would have hoped if it's indeed effective, that we would see benefits more across the comorbidities, but agree with Shabir that it's an extremely blunt tool, especially in old elder adults, so not the best tool.
Thanks, Gary.
Thank you.
Do you have any questions at St. Michael's?
No questions here, thanks. Great presentation, Mauli.
Thank you.
We have time for more questions or comments from anybody else in the audience. You can unmute your mic and go ahead. Opening it up to all participants. If not, we'll ask Ken to get his slide deck ready. Thanks very much, Mauli.
Thank you.
Hi, Mauli. This is Alex P. I have one question for you.
Sure.
How expensive is it to get this machine that detects the light versus deep sedation? I'm wondering maybe if that's a limiting factor for some people and some institutions.
Yeah, so I mean, what they used in the first study, the bispectral index, the EEG, that's not normally used. But the OAAS is often used in surgical settings to look at, to see how deep sedation they have. So I'm not sure about the exact cost of it, but I don't think that's the limiting factor. I don't know if anybody else has an answer to that.
I don't think anybody else in our group has intimate experience or knowledge of this machine, but it's a very good question. Thanks, Alex. It looks like Ken is ready with his slide deck. Hopefully people are seeing it there on the screen, and I'll turn it over to Ken. Thank you.
All right, thanks, Barb. I'm presenting today on the ASPREE studies. I'll start by prefacing, I think I'm really excited to hear what everybody else in the room has to make of the trials. I'll do my best to present what happened in them, but please, I'll try and leave adequate time for questions and comments. So this is the long presentation for our Geriatric Medicine Journal Club, and is on aspirin and reducing events in the elderly. I have no relevant conflicts of interest to disclose. I'm going to start by going over the objectives, but the overall overview is that we'll talk about the existing recommendations for aspirin in adults and in older adults, the ASPREE trial and its study protocol overall, the various outcomes that were looked at in the ASPREE trials, and then a quick critical appraisal of the study before going on to questions. For the objectives, I hope everybody at the end of this talk will know how to describe what the existing guidelines say for the use of aspirin in the primary prevention of cardiovascular events, be able to describe what the ASPREE trials showed, and also be able to critically appraise it and apply the results to your own practice as you will. I wanted to start off with a case. Imagine you have a woman by the name of Erica. She comes to your clinic. She has a medical history of hypertension. She's on Ramipril. She used to play tennis on a regular basis, but has decided this year she wouldn't renew her membership at her tennis club. She just says she just doesn't want to play anymore. You do some basic dyslipidemia workup and also take her blood pressure, and these are her results. Her blood pressure is 138/76, still normotensive by current guidelines. Her cholesterol profile is as follows. She has a normal fasting blood glucose. And she asks you, should I be taking aspirin to prevent a heart attack or a stroke? So that's case one. Case two, imagine you have Ashan, who's a 72-year-old Sri Lankan man. He has a history of smoking. He lives with his wife. He has more comorbidities, hypertension, diabetes, dyslipidemia, GERD, and chronic kidney disease. He's had no prior history of CV events, but he has a strong family history of cardiovascular disease. He takes more medications, ramipril, metformin, rosuvastatin. He's still active. His blood pressure is a little bit higher than Erica's. His cholesterol profile looks a little bit worse with a lower HDL and a higher LDL. And his creatinine at baseline is a little bit more elevated. And he asks you, should I be taking aspirin to prevent a heart attack or a stroke? Okay. So with that in mind, we'll go into the existing recommendations for aspirin in adults. So the evidence based on a meta-analysis done in 2009 suggests that the absolute risk reduction on an annual basis for aspirin is quite low. You're looking at a baseline prevalence of serious vascular events in the overall adult population of 0.51% versus 0.57%. So the baseline prevalence is low, but the relative risk reduction is on the order of 12%. That's a very large number needed to treat, but remember when they're thinking about aspirin and primary prevention, they're trying to amortize that benefit over 10 years or so. So, you know, over 10 years, you might have a number needed to treat. I know that it's not always linear, but you can roughly estimate that the number needed to treat is about 140 over 10 years. But the annual risk is really, we're not talking about a huge change here. That's always balanced by the risk of bleeding, which we all recognize with aspirin. And the effect is on the similar order of magnitude, but it is less than the purported benefit to vascular events. And you can see here, these are forest plots looking for aspirin. This is for non-fatal MI, so one of the serious vascular events. This is a series of trials looking at several different aspirin doses. And you can see that overall, it seems to favor intervention. For non-fatal strokes, the evidence is less clear. You can see that in this forest plot as well, that's sampling similar trials. Now, aspirin hasn't been looked at for just vascular events and also bleeding risk. It's also been looked at for cancer mortality. For overall cancer mortality, they found no significant effect, though there are other more recent, some meta-analyses, depending on how they include trials, whether or not they include just primary prevention trials or primary and secondary prevention trials, they see benefits in overall cancer mortality. But for primary prevention trials alone, no benefit in overall cancer mortality. That's primary prevention for vascular disease. And in colorectal cancer, they do note that there is a benefit, but it only appears if you look at long-term follow-up for mortality. So over more than 5 years, that's when this benefit starts to be observed, and it's only in colorectal cancer. Again, I'll emphasize that these aren't trials looking at aspirin for cancer prevention specifically. These are aspirin in cardiovascular trials where they look at cause of death eventually, and then they find out what killed people, and they notice that when they look at the cancer results, this is what they find. This is a 2016 meta-analysis. And so here, again, forest plots, this is for overall cancer incidence. They find no benefit with aspirin, neither for mortality, but I just didn't print out the slide. And then this is for long-term CRC death. You can see there are these 4 trials. These were TIA, like a TIA trial looking for stroke, et cetera. And here they found that it favors aspirin. So in 2016, the US Preventive Task Force updated their recommendations after doing a decision analysis. What they did was they tried to calculate on an annual basis what someone's risk of having an MI, a non-fatal stroke, colorectal cancer, GI bleeding, hemorrhagic stroke. They tried to calculate what the risk was on an annual basis, what the benefit would be with aspirin, and then they rolled together. They used a model to basically say, you've got a cohort of 10,000 men, they keep aging, they keep aging, they keep aging, they might die from other causes. What is the expected benefit from starting people on aspirin? And then they basically tabulated the results based on the baseline CVD risk and the net life years gained and the quality adjusted life years gained. For those who aren't familiar, quality adjusted life years, they basically calculate the quality of life over that year by asking people, there's a methodology to it, asking people what they would trade off if they had had a stroke or had had an MI or along those lines. And here you can see that in people with the highest CVD risk who are youngest, there is the greatest potential benefit to starting someone on aspirin. So a man aged 50 to 59 with a 20% baseline CVD risk has the potential to gain 605 years, if in 10,000 men, they have the benefit of gaining 605 life years. or 834 quality adjusted life years, because the evidence is different between men and women. If you look at the second line, second set of data for women aged 50 to 59 with a 20% CVD risk, they can gain, 10,000 women may gain 463 life years or 833 quality adjusted life years. So it's a positive number, it looks kind of good. They didn't look at cost. I tried to calculate though, what's the denominator here, right? You've got 400, 500 life years gained, but out of how many life years are you making an impact? And I just did a rough back of the envelope calculation. If you're assuming these age 55 individuals are living to 80 years, you're averaging the life years gained between men and women, and you're looking at a baseline CVD risk of 15%. You're gaining 365 life years or 680 qualities out of 250,000, because you've got 10,000 men or women who are going to be living for presumably 25 years, assuming that life expectancy. So it's not a huge benefit. So remember, the big question about aspirin is that you're looking at the competing risk reduction associated with vascular events, which was a 12% reduction. But this model accounted for the fact that people die of other things than just cardiovascular disease. And so it's really hard to budge that line, but that's just the nature of medicine. It's not easy, but there is an overall positive benefit. The last sort of area that people looked at was dementia, but recall that most of this evidence comes from vascular prevention trials, and you need to power a study or plan to look for dementia in order to find it. And so the evidence is not as good for aspirin and looking at dementia as an outcome. So I looked at the Canadian guidelines and the American guidelines based on this evidence. And the Canadian guidelines, they are more cautious about applying this evidence. They basically say that you shouldn't use aspirin in the routine prevention in anybody if they don't have any vascular disease. But they say in special circumstances, apologies for the typo, where the vascular risk is considered high and the bleeding risk is low, then maybe you can consider it. And you can see their comment in their writing. They say, though vascular events may cause disability and mortality and the cost is low, a clear margin of benefit must apply before recommending therapy to a vast, healthy population. Now, the US guidelines are a little bit more prescriptive. They basically say if you're age 50 to 59, and remember, they're the ones who did that tabulation, and your baseline CVD risk is greater than 10% in 10 years, just initiate the low dose aspirin. They give it a grade B recommendation. When you're 60 to 69, they say, well, you can think about it. And they basically, they ask you to essentially what they're saying is that if there's a 12% relative risk reduction, calculate your cardiovascular risk. If you have a high cardiovascular risk, well then, you've got a 10% 10-year risk. You can make it maybe 9 or 8%, and that might be that's probably a meaningful result for an individual. You're preventing an MI. You're not factoring what else they might die from, but you want to reduce their cardiovascular risk. It's just aspirin, why not? And so they give you this calculator. The website is included below. You can basically plug in someone's cardiovascular profile, and they'll crunch out a risk. So looking at our patients, Erica, her 10-year ASCVD risk was 24.1%. Okay, it's highly modulated by their age. And Ashan, his 10-year ASCVD risk is 56.6%. But that's what you do when you put it in the calculator. They do comment, though, that for adults age 70 or older, there's no clear recommendation just because the evidence powering that information is not great. They didn't have too many older adults in the study. When they did subgroup analyses, though, they found that the effect seemed to be greater in older patients. And so they left their review in 2016 by saying, we conclude that the subpopulation differences in aspirin use had an enhanced effect on MI in older adults, but a large ongoing trial of 19,000 participants aged 70 years or older may confirm this finding. And that is the ASPREE trials, which we'll discuss today. Okay, so the ASPREE trials, we'll try and move through them. September 2018, 3 papers come out in NEJM. They're looking at men and women over the age of 70. They used enteric-coated aspirin, 100 milligrams daily. It was placebo-controlled. They looked at disability-free survival, which we'll dig into a little bit later, and they looked at US and Australian participants, mostly Australian. They excluded people who had reasons to be on aspirin for secondary causes, for secondary prevention, vascular events, also atrial fibrillation, which would be another indication, people with allergies, bleeding diatheses, and people for whom the outcome had already occurred, dementia, functional impairment, etc. They also excluded people who are non-compliant with medications. They looked at disability-free survival. This was the first major paper that was published on it. They looked at the first occurrence of death, incident dementia based on DSM-4 criteria, and then persistent physical disability was defined as difficulties performing a basic ADL, eating, ambulation, toileting, etc., for at least 6 months. And for secondary outcomes, they looked at the more classical outcomes: overall mortality, cardiovascular events, hemorrhage. Here they did look specifically for dementia that factored into their primary outcome. They looked at MCI, physical disability, cancer because of the interest in cancer. And this was a randomized controlled trial. They had a 4-week run-in period to determine whether or not people were compliant with their aspirin, and then they checked in on them annually to look for the outcome and how they were doing and the development of comorbidities. And they also checked in at 3 and 9 months, roughly 3-month intervals in between, just to call and find out if everything was going okay. They analyzed their results by intention to treat, a Cox proportional hazards model. They're looking to survival, time to first event. And then also for their secondary outcomes afterwards, they corrected to recognize they looked at many secondary outcomes and they needed more stringent criteria for what constituted a statistically significant event. They used what's known as a Bonferroni adjusted correction. They also did several pre-specified subgroup analyses. I won't get into just because there are a lot of them and none of them were really significant except for one, which we'll show. So here are the trial results. And what I'm going to do is I'm going to go through each of the 3 papers because the protocol for all 3 is the same. They screened a lot of patients, they randomized a lot of patients, and everybody more or less stuck with it, which is really quite impressive given the number of patients that they screened. Their baseline characteristics: the median age was 74. It was a predominantly female, though only lightly so, population. It was a mostly Australian population. It was an overwhelmingly white population. They had great difficulty recruiting Black and Hispanic individuals. They made specific efforts to, but were unsuccessful. And they found that the patient population that you're looking at vastly is free of too many comorbidities. We'll get into that in later baseline characteristics. The chief comorbidity people had was hypertension and or dyslipidemia. And then some had a personal history of cancer. They were overweight but not obese, very few smokers. I think the big picture that we use in geriatrics is what was their frailty. They modified the Fried Frailty Index. Most people were not frail, meaning they had normal body weight, no decreased strength, no complaints of exhaustion, normal walking speed for age, and regular physical activity. Most were not, almost all were not frail or pre-frail, meaning they only had 1 or 2 of those criteria, and very few had previous aspirin use. They allowed people into the trial if they used aspirin for primary prevention reasons. As long as they agreed to randomize, their doctor okayed it, and then they could stop. So 10% were on aspirin already for some sort of primary prevention. Now, I'll just go through the additional baseline characteristics that are available in the supplementary index, just because they add a little bit more description to the people in the trial. Most were not living alone, so probably with a spouse, I presumed. Many had only 1 or 2 morbidity conditions. Most did not have polypharmacy. Most were not on a statin. Most were never smokers. You can see, generally speaking, their gait speed, their grip strength, their modified mini mental status. These are all good numbers. For gait speed, if you recall, a timed up and go, which would include also the sitting up and sitting down and standing up, is you're looking at 10 seconds for a healthy adult population. So they walk quite briskly, 3 meters. We can try it if you'd like. Grip strength, these are normal, around normal levels for age, and then modified mini mental is out of 100. Remember, they didn't want people with dementia already. And this is their baseline cardiovascular profile. These are numbers similar to Erica's. These are quite favorable, with a little bit of a high systolic blood pressure in the context of sprint senior. And the creatinine I also noticed is a little bit higher than I expected. The study design, they were able to complete their study. They followed for about 4.5 years, 4 to 5 years. And they stopped the trial a little bit early just because there was so much ambivalence in the primary outcome between the intervention and control arms that they felt that further follow-up would not lead to a statistically significant result. And generally speaking, everybody stuck with the program. They showed up for their visits. They did not all take their pills. This was a percent of pills taken. They counted pills when they came back in. I find that just to be a very interesting number because this is just how often your patients take your pills. So just so you're aware. Yeah, and then many were not still on study drug at the end, but that's because they developed conditions for which they might not be on it. So first paper, disability-free survival. Hazard ratio is 1.01, really no difference in the composite outcome nor any of the composite components. Also, if you look, the numbers are a little bit different when you look at the composite components because the composite outcome looks to time to first event of any of those three. If you look though for death from any cause, there's a statistically significant, it depends how you calculate it. There's a statistically significant difference if you use a p-value of less than 0.05, but remember, they looked at several secondary outcomes and it's more likely you can find an outcome by chance if you just keep looking for outcomes and looking for outcomes. So this is not a significant result if you apply a Bonferroni correction. But in the population, like that's if you're trying to apply the population values to the rest, sorry, the sample's result to the population, but for this sample, more people died in the aspirin group. Major hemorrhagic events was the safety outcome, and there was greater incidence of hemorrhage. And hemorrhage, a significant hemorrhagic event required a transfusion, hospitalization, surgery, or cause death. Now, on subgroup analyses, the same neutral hazard ratio was seen through all groups except for in the not frail group. But here they comment that you really can't interpret it because the direction of effect was not consistent. And in the not frail group, it favored placebo, but then in the pre-frail group, it favored aspirin, and the not frail, and then it favored placebo again. So they said this just for interest. All-cause mortality, they dove a little bit farther into their mortality data to try and find out why in their sample more people died. And the driving number here in their sample was cancer deaths. Interestingly, when you look, so this is the graph, you can see it's a small number overall, but when they zoom in, you can see it starts to pick up after 3 years of follow-up that the mortality due to cancer starts to rise. Interestingly, when you look at the types of cancer, again, the numbers are quite small, but it's just interesting given the previous results for colorectal cancer. The hazard ratio is largely driven by the increase in colorectal cancer deaths. And it's interesting, they tried to find out why this was the case. They didn't find a higher incidence of cancer when they started looking at charts. And then they asked, well, maybe you have people with colorectal cancer, you start them on aspirin and they bleed out. They tried to look at the proximal cause of death in the charts. It's not because people died of bleeding most acutely. So those are just the results. They tried to find out why. They looked at for an interaction, they found that it happened more in Australian participants, but they also did not interpret that. Again, probably reasonably because this is a secondary outcome. They're just trying to find out why in their group or that population, in the sample that they chose, this happened. Lastly, the third paper was looking at cardiovascular events and bleeding, again, more in line with previous trials. Here, you'll look at the incidence of cardiovascular disease, and really it's neutral across both groups. I will comment that if you look at major adverse CV events, you can see that the incidence rate, unfortunately, this is rate per 1,000 person years, which is not the same as your ASCVD risk, but recall, they followed these patients for about 5 years, and you can see that the incidence rate is about 3%. And so you can see that if you think about Erica, who is the average patient included in this trial, her projected ASCVD score was that she would have a 22% likelihood of having a CVD risk event in 10 years. And here, at least in 5 years, only 3% of that population ended up having an event. So maybe there are some comments that aspirin in the modern era of statin therapy and sort of modern revascularization, or actually this is primary prevention. So, but aspirin in the modern era of statin therapy and blood pressure control, it may not be as effective. There's changing, the context has changed in the time between when those other meta-analyses were conducted and this trial was conducted. For hemorrhage, though, the hazard ratio is clearly higher. It's really, really clear. You can see just that they diverge right away. Aspirin causes bleeding. So I do want to make a comment also, only because they included it in their results section. They comment just on whether or not these results can be applied towards deprescribing. And they mentioned that since only 10% were on aspirin to begin with, technically this is not a study of deprescribing. This was a study of mostly people who were not on aspirin to begin with, and we started them on it. So critical appraisal of those were the results. Critical appraisal, it is a high quality trial, right? It's a randomized, blinded, placebo-controlled trial. They recruited a lot of people. It was adequately powered. They analyzed by intention to treat. Everybody followed up. And the treatment effect, really, there was no benefit. And I converted the event rates into a number needed to harm, just in terms of aspirin and major hemorrhagic events. And the number needed to harm is about 420 over 1 year. And then I also calculated based on the confidence interval what the number needed to harm would be. And so that's, it's not a huge number. It's not a concerning number needed to harm, but it is a concrete one. Now, I think that the limitation in this trial is largely whether or not the results of this trial applied to the person sitting in front of you. So I said that results help you in caring for your patient, yes, but with some limitations. To review again, it's a high quality trial, but the big issue is that it was in a mostly white and healthy population. For people who are looking at cancer potentially as an outcome, the people will probably make comments that, remember, you didn't see the CRC benefit, CRC mortality benefit until you stretched your study span to 20 years, and you only followed for 5 years. So maybe there was something that happened, but if you really followed it out, you'd actually be preventing colorectal cancer in this population. The increase in cancer risk, they comment, should be interpreted with caution just because it goes against previous evidence. And again, it's a little bit limited in whether or not we deprescribe aspirin. You can still do it, just the evidence informing that practice isn't really supplemented. It's not strongly answered by this trial. I will also comment that this trial comes out in the past 1 to 2 months in the context of 2 other big trials for aspirin and primary prevention. One was in groups of patients with diabetes, a big trial. There was a benefit for vascular events, but the bleeding risk, they commented, compensated for the vascular benefit. And then the ARRIVE trial was looking at patients with an average cardiovascular risk and found no significant benefit. And so we'll just go back to the case. Case 1, Erica, she asks you, should I be taking aspirin to prevent a heart attack or a stroke? My opinion would be for her, no, she's not on aspirin to begin with. She had that 24% risk, but the newer evidence seems to suggest, and this was a high quality trial powered specifically for people like her, it didn't have a benefit, and it suggests that maybe her CVD risk is overestimated by those calculators. I think the question is still out for someone like Ashan, who has a very, very high risk, has strong family history. He just doesn't fall within this trial, and so this trial doesn't really answer the question for him. So there's now strong evidence for no benefit for low-dose aspirin in primary prevention in healthy adults over the age of 70, even with a high CVD risk calculated by the ASCVD score. But for very high CV risk and patient populations who are not mostly white, I think that there's a question as to whether or not it's still out there. That's my bottom line, or at least how I've interpreted the results. So hopefully you can describe what the existing guidelines say, compare how the ASPREE trial comments on them, and then critically appraise and apply to your own practice. Thank you to Dov Gandel, who recommended, calculating cardiovascular risk profile for the average ASPREE patient. And I'll leave it now open to questions and comments.
Terrific. Thanks very much, Ken. Do we have questions from Baycrest?
Ken, thanks very much. That was a very nice presentation. I guess, the story of aspirin has sort of gone up and down over the years. This is obviously a very large study in a very homogeneous population, as you point out. So I guess the one thing that's hard to refute, that's pretty clear, is the significant hemorrhage risk, like major bleed risk, which, clearly that is a significant risk with people on aspirin. So even in your, the second case that you presented to us, which, the very high, over 50% risk, I guess you would have to have this discussion that the benefit is unclear, but we do know that you likely will have a significant increase of having a major bleed. So that's just, I guess, a comment. The question I have relates to the thing that's a bit of an enigma here, which is the colorectal cancer risk. If you look at the previous studies suggesting benefit versus this, is there any clues at all why they may have come up with virtually an opposite result, either in choice of population or other aspects that would explain it?
They actually comment that they're really not sure. They kind of hand wave and comment that aspirin has multiple effects on the body, pleiotropic effects, and they didn't really come up with a clear explanation for it. And they comment that really they don't want to look too far into it because it was a secondary outcome. I will say, and unfortunately I didn't have the time to look it up and add it to the trial, to the presentation, but my roommate is in medical oncology and I trialed my presentation with him. He commented that there was a recent trial done that showed a positive benefit for aspirin called the ASPEX study. And so I haven't had a chance to look into it, but there may be another trial that looked at longer term outcomes. And I'm sorry that I didn't bring that to the table for discussion, but for people who want to look into it, apparently a recent trial has looked into this, specifically looking at cancer.
Do you think that it may relate at all to prior risk of colorectal cancer? In other words, if it's targeted more to people at high risk for colorectal cancer, that the outcome may be different than if you just take a larger population?
The original trials that showed the benefit were, again, looking at vascular events. So these were secondary analyses of trials trying to prevent cardiovascular outcomes. So technically, it's kind of a similar population. So it's, yeah, it's a good question.
Should we go over to St. Mike's? Looks like Karen's trying to unmute her mic.
Hi, Ken. Sorry, I was having trouble with the microphone there. Great presentation. My question, well, two short questions, hopefully. One is, what do you think about the use of creatinine for older adults rather than, for example, EGFR creatinine clearance? And second, in the study and how it would apply clinically. And then the second question is about dosing. So obviously the dosing in the US and Australia is different from what we have here in Canada for what's available for aspirin. And would that affect your choice? Do you think it's fair to extrapolate the results for what we have here in Canada, which is 81 milligrams?
Yeah, good questions. So for the first question about GFR versus creatinine, obviously the GFR is a more useful calculation as the creatinine should really be normalized against someone's body weight. That said, it didn't seem like it was a very frail population. The average BMI was 28. And so I think that you have to interpolate from it. It is the data that they collected and they didn't crunch out a GFR for every single patient. But I do think what you're getting at when you talk about dose and GFR is just that the new information from the meta-analysis looking at increased hemorrhage events for patients on aspirin, for particularly for people who are more frail and who are have lower body weight. And so unfortunately, obviously that meta-analysis came out when this trial had already collected all of their data. And I do think that it's worthwhile discussing. I was curious to know what other people would think about it. For the people in the room who are not familiar with it, there's basically a suggestion that we might be overdosing aspirin in frail adults with poor renal clearance and also low body weight. And if you used a lower dose, even something below 81 or maybe 81 every other day, you might be able to attenuate the bleeding risk while still having the benefit for cardiovascular outcomes. But obviously this trial can't comment on it. This is a single high quality data point from which you can continue to extrapolate for your patients.